We're somewhere in the middle of the slide packet. I think this is slide 21, something like that. And our book in chapter 2 just pauses for a moment and brings up this idea of phosphorylation as a common theme, a common way to achieve signaling. We just saw a few minutes ago how phosphorylation could do something. It could cause desensitization of the receptor. Right? Last lecture we saw how phosphorylation of a substrate can cause lots of things to happen, like transport of ions across the membrane, gene transcription, DNA. And so phosphorylation, our book looks at as a common theme, and it uses the term, our book uses the term reversible phosphorylation as being involved in almost all second messenger systems. So, when you look at some of these early slides, you'll see that cyclic AMP stimulates a kinase in cells called PKA, protein kinase A. It's also known by some other name. But that second messenger stimulates a kinase. The kinase does what? Phosphorylation. Right? You're going to see that activation of GQ-coupled receptors results in increased calcium second messenger in cells, increased phosphoinositide second messenger in cells. Those actions result in a kinase being activated called protein kinase C. C stands for calcium. A protein kinase activated by calcium. Also in that pathway, we see another protein kinase called calcium calmodulin dependent protein kinase. So second messengers are usually doing something to kinases that are involved in phosphorylation, which helps propagate signal. I don't particularly like the term reversible phosphorylation because it's not really self-reversible. Right? Once you phosphorylate something, it stays that way until phosphatase comes along. You know, reversible binding of drug to receptor means that agonist binds and eventually falls off and gets carried away and ends up in the urine, right? After metabolism. The drug binds, falls off. It's a reversible binding. Unless you're a irreversible antagonist, and there is no reversible binding. So I'm not a big fan of what the book uses in terms of reversible phosphorylation because it's not self-reversible. You need an enzyme called a phosphatase to reverse it. Okay? Does that make sense? Okay. But, as we have seen already, and as you'll see in some of those early slides of this set, phosphorylation plays a key role in almost every step of signaling, from regulation of receptor, like we saw with insulin receptor, autophosphorylation, and receptor tyrosine kinase, as we saw in desensitization of beta adrenergic receptor, to regulation of kinases and kinase substrates. Right, so phosphorylation of one substrate by a kinase results in an effect. And in addition to that, one kinase can phosphorylate another kinase and either turn the second kinase on or turn it off through that phosphorylation. So somewhere on this slide you can write, even kinases can be substrates for other kinases. Have any of you ever heard of the MAP kinase pathway? It's a really important pathway in cancer. It stands for mitogen activated protein kinase. Mitogen stimulates what process? What process do you hear in the word mitogen? Mitosis. And what cells shouldn't really go through mitosis if you want to have a healthy outcome? Tumor cells. Right? We want to stop mitosis in tumor cells to the point we can. But mitogen-activated protein kinases are all about grow, tumor, grow, tumor, grow. So that's another example where one kinase phosphorylates another kinase and activates it. That kinase phosphorylates another kinase and activates it. And there's probably like 4 or 5 kinases in the pathway. So not to get too complicated here, the point of the slide really is to just talk about phosphorylation as being important in signal transduction. And then we can take each substrate phosphorylation one at a time to understand what's happening. So we can think of phosphorylation as a molecular memory, if you will, where a phosphorylation event would record the memory, and a dephosphorylation accomplished through the action of phosphatases would erase the memory. Okay, and so that's one of the things, one of the examples we can use to think about the importance of phosphorylation. And lastly, second messengers like cyclic AMP, calcium, or cyclic GMP can use the presence or absence of kinases or kinase substrates to produce different effects in different cell types. So what I mean by that is we don't have a universal pathway for substrate phosphorylation and what it means. Phosphorylating a substrate in the liver might do something that the liver needs to do. Phosphorylating a substrate in nerve tissue might be useful to nerve tissue and not liver tissue. So to be very kind of broad and general about it, when it comes to substrate phosphorylation and the consequence of it, we need to know a little bit about the system we're talking about. Right? Are we in the liver? Are we phosphorylating something that's going to activate glycogen synthase? Are we in a tumor cell? Are we phosphorylating something that's going to activate a MAP kinase pathway? Right? So to understand what the consequence of phosphorylation is in a particular cell type or a particular tissue, we need to know a little bit more about the context. Right? So I gave you an example in receptor tyrosine kinase, an insulin receptor, where one of the substrates is called IRS, insulin receptor substrate. And its phosphorylation causes glucose transporters to get inserted into the surface of target tissues. So all of a sudden, instead of having one glucose transporter on the surface of skeletal muscle, you have 5,000. And a lot more sugar can enter into the skeletal muscle than could if there was no signaling by insulin. Is that kind of making sense? So think, when it comes to substrates, where am I? Or what would the substrate do if it's activated? Am I in the liver? Am I in the fat? Am I in the neuron? Am I in the glial cell? Where am I? Because you'll hear about phosphorylations in other courses and other systems. So for the principles portion, phosphorylation means something has changed. So what has changed and why is that important? Those are the questions you should ask. What has changed and why is that important? Now, the next part of our book starts to talk to us about receptor classes. And it brings out some important concepts that we should tackle together. The first concept is that the same chemical can act on completely different receptors. And that I find to be very pharmacologically exciting. Right? So the same chemical can act on totally different receptors. And so an example of that you may have already encountered in anatomy and physiology, acetylcholine. Right? Acetylcholine released by the vagus nerve can slow your heart down by activating a muscarinic receptor in the heart. Right? Remember which G protein is coupled to the muscarinic receptor in the heart? Is it a stimulatory G protein that stimulates the heart, or is it inhibitory? Inhibitory. Right? And what was the other thing that GI activation did in heart cells? Remember? A certain type of channel, heart cell gets open. Potassium channel. Right? Very good. And so the heart slows down. Right? So acetylcholine can bind to those muscarinic acetylcholine receptors. In the heart, it would be GI, which I obviously didn't list here. Right? But for example, in smooth muscle that makes up part of your bladder wall, that would be a GQ coupled receptor that also responds to acetylcholine, promotes urination. Right? So acetylcholine can activate nicotinic receptor, can activate muscarinic receptor. It can activate different subtypes of muscarinic receptor. So what's drawn on the slide is GQ. It can also activate GI-coupled receptor in the heart. That's pretty cool. One agonist, multiple receptors. And if you look at the receptors, it's totally different. One is a fast-responding ion channel, and one is a little bit more slow-responding G-protein coupled receptor. And so we see other examples of one agonist, multiple receptor in systems that we're going to talk about later in the course. So not just acetylcholine, but norepinephrine. Now, norepinephrine is an important neurotransmitter in the central nervous system, but in the autonomic nervous system, norepinephrine can act on beta receptors, okay? Particularly beta-1 receptors in the heart, which are coupled to GS. And so which second messenger goes up? Cyclic AMP stimulates heart contraction, increases heart rate, also known as positive chronotropy. Right? Positive chronotropy. Also stimulates strength of contraction, positive inotropy. And so we revisit this later in the course. But example of one ligand, multiple receptor. Norepinephrine also activates alpha receptors throughout the vascular smooth muscle. And it can activate subtypes of alpha receptors, such as alpha 1 in the smooth muscle, or alpha 2 throughout the ANS. Right? So one ligand, multiple receptors. We see this in pharmacology often. And so this is why you may give a drug for a certain purpose, and the desired receptor will fix the problem, but this other receptor might generate an adverse effect. And you can't really separate the two, because the drug has affinity for both receptors. Okay, so we're going to talk about norepinephrine again in later chapters when we get to sympathomimetics and drugs that act like it and drugs that inhibit it and the pharmacologic consequences of such. But here in chapter 2, it's coming up as an example of one agonist, multiple receptor actions. And I would just write here somewhere, does not stimulate beta-2 receptor. Right? You don't see anybody in your pharmacy getting dispensed a norepipen, do you? Which pen do you see? EpiPen, right? Epinephrine pen. So, and the reason for that is to open up the bronchi. So norepinephrine's effects on the bronchi are very, very minuscule. That's why you don't have a norepipen. But again, we'll encounter that in later chapters. So here, one agonist, multiple. Now, the next compound I want to discuss is a drug called tamoxifen. Tamoxifen is an anti-cancer drug. It's used to treat breast cancer. And the reason why it works in the treatment of breast cancer is because it acts as an antagonist on estrogen receptor in breast tissue. So estrogen can be classified under the umbrella of mitogen, right? And mitogen, we talked about a little bit ago, does what to cell? It causes cell proliferation. Now, the females in the room will know that their estrogen levels fluctuate throughout the month, right? And there may be periods of time during the month where they feel some tenderness of the breast tenderness. Why? Because this compound has mitogenic action. It can stimulate some proliferation of ductal cells. It can stimulate proliferation of the endometrium, right? And so if there is no pregnancy, what happens? You get a sloughing off the endometrium, right? And you have the menstruation, right? So we know that estrogen can cause cell proliferation, right? It is mitogenic. And the problem in breast cancer is that estrogen can feed the tumor. right? So the breast tumor likes estrogen because estrogen tells it to grow. And so one approach to treating estrogen receptor positive breast cancer, this isn't meant to be a breast cancer lecture, and unfortunately many tumors don't respond to tamoxifen because they're estrogen receptor negative, but that's a topic for another day. But breast tumors that are estrogen receptor positive do respond to tamoxifen because tamoxifen does what to the estrogen signal? Blocks. Right? So useful as a treatment in breast cancer. Now, women who were being treated with tamoxifen for breast cancer were found to have a second benefit of the drug. And the reason now that we understand is because tamoxifen is actually, we can't call it an antagonist or an agonist, really. We call it something called a SERM. And a SERM stands for Selective Estrogen Receptor Modulator. Modulator could be something that stimulates or something that inhibits. Have you heard the term SERM, like in MedChem? Okay, so you're going to hear about SERM in future courses. But SERM stands for Selective Estrogen Receptor Modulator. And so if you walk into the room and you say, I'm a SERM, you need more evidence and information to make a decision on me. Because it means that you might activate or you might block a receptor. You're a special kind of pharmacologic agent. You can act as an agonist, you can act as an antagonist. Kind of weird, right? So you're a SERM. You get put into this kind of mixed group. So tamoxifen is a SERM. In mammary tissue, it acts as an antagonist. In bone, it acts as an agonist. So, okay, what happens to women during menopause in terms of their estrogen? Estrogen level will stay the same, go up, or go down? Go down. And what other disease tends to affect women who are postmenopausal in terms of their posture? Osteoporosis. Very good. Right, so the bones start to get brittle because estrogen levels have fallen. So osteoporosis tends to be a disease that affects postmenopausal women. What we know today is that estrogen actually stimulates cells in the bones to remodel. Right? So have you learned about bone cells? You've learned about osteoblasts and osteoclasts and bone builders and bone breakers, and they kind of get a balance and you get bone remodeling. And when you remodel the bone, it's strong. And when you stop remodeling the bone, it gets brittle and prone to break. So it just so happens that breast cancer and osteoporosis tend to happen about the same time. Well, I should say one broad type of breast cancer called sporadic breast cancer tends to affect women in their 50s that are postmenopausal. Reasons for that we can go into on another day, I imagine. But not all breast cancers fit that phenotype. If you've ever heard of the BRCA genes, BRCA breast cancers are hereditary. They run in families. Your mother may have it, your grandmother may have it, your aunt may have it. You have a gene mutation. Any of you who have followed Angelina Jolie, she's an actress, she has a mutation. Those cancers can affect you at a younger age. They can affect you as young as 30 years old. So those are different. And thankfully they're rare. We make them about 10% of all cases each year. But there are certain families where they are prevalent in risk of women where breast cancer is high in those families. But anyway, getting back to this bone estrogen connection. So women were being treated for breast cancer who had osteoporosis. The tumors were slowing down, they were living longer, and they were getting less osteoporosis. So scientists started to study the effects of estrogen on bone, and they found that estrogen had a good effect on bone. And for many years, women were given estrogen replacement therapy when they went into menopause. Until about 10 years ago, a big study came out that showed giving estrogen back to a woman in menopause increases her risk of uterine cancer and increases her risk of heart attack. Right? So you may have read about that in your public health book in the epidemiology chapter, which is called the Women's Health Initiative. I know I talk about it in public health. I don't know if there's another fact. But you have the book. It's an interesting study from a knowledge standpoint. So, estrogen, good for bone. Estrogen, bad for breast cancer. Block it in the breast cancer patients. Stimulate it in the bone, osteoporosis. So here's an agonist. Well, here's a drug that acts as an agonist in bone and an antagonist in memory. That's weird. How can that be? And the answer is, well, we're not really sure. We think that there's some downstream molecules from the receptor that determine whether it's an agonist or an antagonist. We don't really know yet. Your book has a very complex model, and I'm not going to have you memorize it because it's unclear. Okay, but the current belief is that something downstream of the receptor is going to dictate whether tissue acts as an agonist. So here, antagonist in breast, agonist in bone, and partial agonist in the uterus. So one of the things that we learned from women who were treated with tamoxifen for breast cancer was the risk of osteoporosis went down, but the risk of uterine cancer went up. So here they are, being treated for breast cancer with a drug that helped, but the risk of uterine cancer went up. Right, so these days, if a woman's a candidate for tamoxifen and she's actually a positive tumor, she might go through a hysterectomy so the drug will work well on her and not increase her risk of uterine cancer. What is a hysterectomy? Removal of which organ? The uterus. Right, so it's a complex thing, this tamoxifen. But, it's a good example to use when we're talking about agonists, antagonists, one drug, multiple receptor kind of thing. Right? So antagonist in mammary tissue, agonist in bone, partial agonist in uterus. And that makes sense because it acts like estrogen in the uterus, and estrogen does what to the lining of the uterus? Causes it to proliferate. Right? So if there's a pregnancy, that then gets even more proliferated with progesterone, and the uterus gets prepared for the baby. If there's no pregnancy, the lining slops off, and we start. Okay, so I don't know if you're astonished, but I'm always astonished when I talk about tamoxifen because it's just really pharmacologically interesting. Okay. So why do we have, antagonist action in breast, agonist action in bone, partial agonist action in uterus? Again, there's complex drawings and things we could say in various textbooks. But really, we believe the current model or the current idea is that the different cell types express different accessory proteins downstream of the receptor, which are going to affect whether or not that compound is going to be an agonist or an antagonist. Okay, so different accessory proteins in the tissues may be contributing to that. Right, and so this property of being an agonist in one tissue, being a partial agonist in another tissue, being an antagonist in another tissue, this is what we mean when we say SERM, modulator, selective estrogen receptor modulator. Modulator means it could induce or it could inhibit. And so you need to know more if you just hear the word SERM. Right? There's a new one out on the market called SPERM, selective progesterone receptor modulator. Right? So in some cases it'll activate progesterone receptor, in other cases it'll block. And you'll learn about those in future courses. Okay, so here we've sowed the seeds with the fact that you can get these different possibilities. Is that okay? I recently came across this thing on YouTube called New. Any of you watch it? Jimmy Fallon? Isn't it great? It's so great. You gotta watch it. It's so good. Ew. Yeah. Alright. So, is one you've seen a couple times by now. And it's the S-shaped curve with the linear mid-portion. That means we're log scale, right? A little bit of drug, a little bit of an effect. A little bit more drug, a little bit more effect. A little bit more drug, a little bit more effect. Eventually I get a maximum effect. This type of dose-response curve is called graded. It's called graded because at any point on the curve you can measure an effect. Right? So you can have a little bit of an effect, a little bit more of an effect, a little bit more of an effect, and eventually a maximum effect. Graded means you can measure it at any point on the curve. And I'm going to eventually now move into a topic called quantal dose response in a few minutes, which is different. So for the moment, feel comfortable knowing that a graded dose response curve means that I could measure the effect at any of these points on the curve. Now, graded dose response curves are useful because they start to tell us things about drugs in comparison to other drugs. Right, so up until now, we've kind of been showing these curves as single things or maybe in the presence of an antagonist and what it might look like. Here on this slide, we're comparing two drugs to each other for the same purpose. So maybe these are both antihypertensive drugs, or maybe these are both antidepressant drugs, or maybe these are both drugs to treat inflammation. Whatever the case may be, if we plot dose of drug, or here we've got concentration. So concentration of drug versus effect. We can see a little bit of drug, a little bit of a response, and eventually we get up to maximum response. Right? And so here we have two drugs, drugs A and B, that are both equally good at achieving the maximum response. Right? They both can achieve 100% effect. Would you agree? Right? So we would say that these are equally efficacious. Right? Efficacious. They're equally efficacious. They have the same maximal efficacy, the maximum effect. The drugs A and B are equally efficacious. But we use those EC50 values. Do you remember what I said last time? What do we use EC50 to determine? Which pharmacologic categories? Potency of the drug. Right? So if we were to compare drugs A and B, while yet they have the same efficacy, they differ in potency. The EC50 of drug A on the x-axis is much lower than the EC50 of drug B. Right? So if you were to compare them to each other, drug A is more potent than drug B. So you need a lower dose of drug A to elicit 50% maximum response than you do of drug B. And so you might say, well, why is that even relevant? Who cares if they both give me the maximum response? Well, the reason why it's relevant is because of something we haven't discussed yet, called toxicity. So generally speaking, the more drug you put on the body, or in the body, the more likely you're going to have toxicity. Right? So the theory is, you give the lowest dose that gives you maximum effect. Does that make sense? The lowest dose to a patient gives maximum effect to hopefully avoid any kind of potential toxicity. Is that intuitive? You want to give the least amount you have to get the maximum effect. And so, in this example, we've got two drugs, A, B, and C. They both give the maximum effect. Drug A is more potent than drug B. Does that make sense? Any questions? All right, well, here we have a third drug in the class. We've put on a curve for drug C. And drug C, what can we say in terms of its maximal efficacy? Is it as good and as efficacious as drugs A and B? Go from low concentration to high. Do you ever get the same maximal efficacy? No. But listen to what I'm about to say. Drug C is the most potent of the three drugs. Why? Why is drug C the most potent? Because what is EC50 based on? EC50 means 50% concentration of that particular drug's maximum effect. Not of the theoretically maximal effect. Right? So if drug C's maximal effect is coming in here, 50% of it would be here, right? And so you draw a line over to the curve, you drop it down. This is the lowest concentration that gives me 50% of the drug's maximum effect. So obviously I did this for a reason, because the definitions are not all interrelated. Potency is defined strictly according to the drug's maximum effect, not the theoretical maximum effect. But efficacy relates to the theoretical maximum, right? So drug C is less efficacious than drugs A or B, but more potent than drugs A or B. Does that make sense? So then you might say to me, well, Dr. Bilak, why then would I ever use drug C? I'm working at Merck, and I've been working on a project for 7 years, and the project is drug C, and we're putting it into clinical trials. So why on earth would we ever want to develop that drug? Well, maybe drugs A and B cause a fatal arrhythmia in 1% of the patients. Or maybe drugs A and B cause a dangerous bone marrow suppression in 5% of the patients who might get an infection and die. And drug C, maybe it doesn't do that. So I can give it to a cancer patient who's already at risk for an infection, right? Because it's not going to suppress the bone marrow like drugs A or B will. Right? So in real life, you kind of, the physician, the clinician, you guys, you're going to come up with an approach that's best for the patient based on all the other factors. You know, all things being equal, you'd like to give them the most effective drug. But if the patient's got allergies to drug A, to drug B, or if the patient's got genetic polymorphism that causes them to rapidly inactivate drugs A and B because they're similar in structure, but drug C is a totally different structure, and their body will use it better. Is that making sense? Because it's still early for me. The rain messing me up. I woke up, I thought it was Saturday. But alas, it was Friday. So efficacy, right, that maximum effect, is going to depend on certain factors, like the route of administration, or how well the drug is absorbed, or whether or not the drug can distribute throughout the body, right, or clearance from the blood, or the site of action, right? So maybe drug C is the best drug to use because, going back to that neuroblastoma model, maybe drugs A and B are great in vitro. They don't cross the blood-brain barrier. Drug C is not as good at killing the neuroblastoma cells, but it does cross the blood-brain barrier. You probably have a better shot with that drug than with the other two, right? So, you know, you got to think about some of the other factors that are going on, right? Maybe drugs A and B you have to give through an epidural injection in the hospital. Maybe drug C you can give by mouth at home, right? So, you know, these factors can affect efficacy or impact efficacy. Now, the graded dose response curve is limited in some instances. You know, while it's a nice curve and it allows us to measure effect at every point on the curve, sometimes it's not possible to kind of measure in between responses. So what do I mean by that? Well, if you have an either-or event, an either-or event, sometimes called a quantal event, is sometimes the goal of the therapy, right? You want to either prevent the convulsion or the drug doesn't prevent the convulsion. You don't get like half a convulsion. That's not how the drug works, right? Or you want to either give the drug to stop the arrhythmia, right? You want to stop the arrhythmia. You don't want to have half an arrhythmia. Right? You can't even have half. Right? Sometimes the responses you're measuring are yes/no responses. You either had the convulsion or not. The patient's arrhythmia either went away or it didn't. The patient survived or died. Right? You're not like half dead. That's not a desired outcome. You just survived. So these would be considered quantal kinds of events. Yes/no responses. Right? So graded dose response curve, you know, in a single patient also has a limitation because it may be only specific to the single patient. Right? So quantal events are going to allow us to see variability from patient to patient. So let's look at that now. Let's say that instead of plotting on the y-axis the response to a drug, you plot the percentage of people who respond to the drug. The percentage of people who respond to the drug versus the concentration or dose. Right, for a yes-no. So maybe this is an anti-migraine drug. The drug either got rid of the migraine or it didn't. Right, got rid of the migraine or it didn't. Right? Half a migraine doesn't help. Right? So if we look at a certain low dose of the drug, only a few people in the population responded. Right? Remember, this is the percentage of responders now. So at a certain dose, only a few people respond. As I increase the dose, now the percentage of responders is a little bit more. If I increase the dose, now the percentage of responders is a little bit more. And eventually I get to a dose where half of the people in the population have responded. Yes? So here we would call that the effective dose at which 50% of the people responded. Right? So we would call it the ED50. But remember, the y-axis here is percent of responding patients in the group. Right? So here's a dose where 50% of the people respond. Is that the dose that the pharmaceutical company wants to manufacture and put in your pharmacies? The dose where 50% of your patients respond? Is that the dose you want to give somebody? No. So which dose would you like to prepare? Your job's on the line. The company spent $30 million to bring the drug to phase 2 trials. Are you going to pick the ED50 dose? Or are you going to pick the ED100 dose? Well, the answer is it depends. Because what's missing here is the toxicity of a drug. So I'm going to show you that in a minute. Right? But what this is meant to show you is that people respond to drugs in a normal distribution. Some people respond to a very low dose of something. Some people need a very high dose of something to respond. And then most people are in the middle. Maybe you're familiar with this when it comes to drinking beer. Right? Some people have one beer and they're completely toasted. That would be me. I don't know why, it just is. Right? So that one beer and that's it. I've had it. I don't need any more. Right? One of my friends from college could probably have 10 beers and seemingly not be toasted. Of course, you would never, ever drive. You should never even drive if you had one, really, in my mind, because your senses are somewhat diminished. But the point is, my friend from college could have 10 beers and seemingly look okay. So he had a high threshold, right? And I had a low threshold. But we both went to the same college. We both had the same body weight. We both were from New Jersey, right? So there is variation in response to drugs, that drug being ethanol. Right? But it's true of all drugs. So people respond to drugs in a normal distribution. And so a little bit of drug, a few patients might respond. A little bit more drug, you start to get more people in the population responding. A little bit more drug, now up to 50% of the population. A lot more drug, eventually I get to a saturation point where hopefully 100% of the patients have responded. And do you notice, log scale, that this is a sigmoidal shaped curve, linear mid portion? So it looks like a graded dose-response curve, but in fact it's a quantal dose-response curve. Why? Because it's plotting percentage of responders versus dose. Right? Quantal dose-response curves, or dose-effect curves, are going to be very useful in determining the safety of a drug. And all the words on this slide I'm now going to say in the next slide. So in an ideal situation, now again, we're using our drug for a migraine headache, right? And we're coming up with the right dose to use in phase 2 trials so that we can bring this drug eventually to the market, hopefully. So in the ideal setting, the purple responders would be those who respond therapeutically. The drug relieves the migraine. The yellow curve would now be toxic effects of the drug on individuals. And so what I'm trying to show you in this model is that the ideal drug would be given at a dose I'm pointing to here, which 100% of people respond, and how many people are showing toxicity here? Are you at a dose where anyone has shown any toxicity yet? No. What if I'm here? All the people will respond, the migraine will go away, but maybe there's some toxic side effect now that's going to happen. Maybe they're dizzy, maybe dry mouth, maybe hypokalemia, I don't know, whatever the toxicity might be. Right? So this yellow normal distribution refers to the fact that people respond to the toxic effect of drugs in a normal distribution as well. So people respond to the therapeutic effect of drug in a normal distribution, and they respond to the toxic effect in a normal distribution. And so in an ideal setting, you would pick a dose of drug where 100% of the patients respond and 0% of the patients exhibit toxicity. That would be ideal. But real life is more like this, where there's some overlap, where the therapeutic effects and the toxic effects may slightly overlap. So if I give this dose of drug, which is going to ensure 100% of the patients who take it respond, am I starting to climb into toxic effects? Right? There's a certain percentage of patients who are going to show toxicity. Right? So when you look at the package insert on a drug, it might have like 40 adverse effects listed and a percentage there. 2% of the patients experience dizziness. 1% of the patients experience constipation. 9% of the patients experience diarrhea. Like, look at the package insert. Look at the adverse effects. You're going to see them presented as a percentage. Right? 0.1% of the patients exhibited bone marrow suppression. 0.01% of the patients died from the drug treatment. Right? That's all listed in the package insert. And it's talking about the overlap of these quantum dose effect curves, one being centered on therapeutic effect, the next on toxic. And then we get to a situation where you might have a lot of overlap. Right? Is this the kind of drug you'd like to give somebody? Where, this dose is going to ensure 100% efficacy. It's also going to ensure that like 70% of my patients have toxic effect? No, right? So you might have to pick a lower dose to avoid the toxic effect. But what do you do to the efficacy? Less than otherwise would be, right? It might not work in all patients. So you see, in real life, you have to deal with the curve and the curves that may overlap. And so while the center of the dose response curve, or the dose percentage of people responding curve, is called the ED50. The center of this toxic curve is called the PD50. The toxic dose in 50% of the patients. We think about ethics, like, would you like to give a toxic dose that you know is going to give 50% of patients some adverse effect? No. So it's going to depend. Like, if this is a drug for migraine, the drug will probably fail, because no manufacturer is going to want to deal with this. But if this is a drug for end-stage pancreatic cancer, where your prognosis is 4 months, and this drug gives you a year and a half, but you have some serious liver toxicity, the FDA might say, okay, because you've tripled the person's life expectancy, even though you've brought on board a lot of toxicity. You see that? Right? So what does this look like for a particular drug? It's unique to each drug, and what are the toxic effects? They might be mild, like dry mouth or dry eyes. They might be serious, like an arrhythmia, right? Or QT interval prolongation, which increases your risk of an arrhythmia. Right? So look at all those adverse effects in any old package insert when you're at the pharmacy in the next couple of days or weeks. Right? So the moral of this story is that there's a therapeutic curve, and there's a toxic curve. And by the way, do you think you can do these toxicity tests in humans? Is that ethical to expose them to a whopping high dose where 100% of the people in the population are having toxicity? No way, right? So how do we do toxicity studies for drugs that come to market? Do we do them in humans per se, or do we do them in animal models? Right? Remember thalidomide caused phocomelia? Right? And later was found to be a teratogen. Well, the way these things are done in pregnant animal models. So you get a pregnant rat, or you get a pregnant dog, or you get a pregnant cow, or whatever, and you expose the animal to the drug, and you look for birth defects. And usually you expose the animal to 1,000 times more than they ever would really use in a human. Right? And you look to see, oh, it caused birth defects in rat pups. The rat pups, died, or they had some problem with their paws or something. Right? So toxicity testing tends to be done in animal models. Of course, if serious toxic effects are seen in clinical trial portion, remember, you have in vitro, in vivo, preclinical studies. You're estimating toxicity in the preclinical studies using animal models. If all looks well, you move into clinical trials. If any kind of weird toxicity starts to show in clinical trials, patients are dying because of arrhythmia, or patients are having a heart attack or something, the clinical trial is going to be stopped because you can't ethically continue it if you know 10% of patients are going to die from this drug, right? So the study will be halted. Does that make sense? So there's an important parameter that I haven't mentioned yet called the therapeutic index of a drug. And all that it is a ratio of the toxic dose of which 50% individuals or animals in the cohort show toxic effects, divided by the dose at which 50% of individuals in the cohort show desired effects. So, toxic dose 50% divided by efficacious dose 50% is therapeutic index. And so, if this is a large number, what does it say about the distance between the TD50 and the ED50? This is a large number. Are they far apart, or are they close? If the ratio, let's say, is 100. 100 to 1. Far apart. What if the ratio is 1 to 1? How do the curves look? They completely overlap. Right? So a therapeutic index of 1 is not going to be approved by the Food and Drug Administration. Would you approve it as a future pharmacist? Therapeutic index of 1? No way. So what's acceptable to you? What do you think the therapeutic index should be? 2? 2 good? Still have overlap, right? 3? 3 or higher? 10? Most drugs have a therapeutic index that are approved on the market between 3 and 4. It's very unlikely to see a drug with a therapeutic index of 10 because that's not usually what happens. And if a drug has a therapeutic index less than 2, it's highly unlikely that the FDA will approve it, unless there's nothing else. Like the patient's going to die from Ebola, the drug will prolong their life by 6 months. So the FDA may consider approving it if it has low therapeutic index. So remember, all this tells you is the distance between the centers of the two curves. The farther apart the two curves are, the better for the patient. But again, these curves are done in preclinical in vivo studies in mice and rats. They don't always accurately predict what's going to happen in the human. And so we do the clinical trials, phase 1, phase 2, phase 3. And at any point, if there's some weird toxicity, the drug gets pulled. Does that make sense? So, the therapeutic index, the true therapeutic index of a drug in humans is almost never known because most studies that involve obvious toxicity are stopped. And so we deal with toxicity studies in animals that are used to estimate the therapeutic index. And so to summarize, graded and quantile dose effect curves provide information that concern the potency and the selectivity of drugs. The graded dose response curve indicates the maximal efficacy. The quantile dose effect curve indicates the potential variability of responsiveness among patients. And when we get into the chapter on pharmacokinetics and we start to talk a little bit about pharmacogenetics, we're going to see that some patients express variability in drug metabolism, for example, where in some patients a drug might stay in the body a long time because they're a poor metabolizer. While in other patients, the drug might never even accumulate in their body because it's just such a rapid metabolizer, ultra rapid, the drug's gone before it can have an effect. So how do we do? Any questions on this idea of the therapeutic index, of the quantal dose response curve, toxicity, efficacy, potency? Okay, excellent question. So the answer is yes. It's just that EC50 is referring to an in vitro study where we're looking at a drug concentration, and the ED50 is looking at an in vivo study with dose. Okay, so what was the maximum response for drug C? Yeah, so the way you determine ED50 is based on the maximum efficacy of the drug that the drug shows you in the study. Not at the theoretical maximum, but what the drug shows. So if the drug can only give you a 40% of max response, where would you go down to find out the EC50? 40% is the max, I'll go down to. 20% is going in line over to the graph. What if the maximum effect is 10%? So that's 5%. So you might say, oh, that's good, 10% efficacy, that would never be a drug for me. And the answer, unfortunately, is sometimes it is. There's nothing else. There are certain brain tumors where the efficacy of the drug is 10%. 10% of the patients respond to the drug. Right? But that's all they have. There's nothing better at the moment. Right? So realistically, it's kind of frustrating because there's a 1 in 10 chance that patient's really going to respond to that drug, that particular drug. I'm not saying all drugs for brain cancer. One particular drug I'm thinking of, whose name I can't remember, its efficacy is 10%. Brand new drug for neuroblastoma. That's the That's why if a company can develop a drug to really cure neuroblastoma, that's going to be the next huge company. Okay.
In terms of inter-individual variation in drug response, there are several kinds of responses that can be used to describe the variation. There are idiosyncratic responses, which are unusual responses very rarely observed in most patients. So an example, patients taking a drug not reported to cause a rash, but in that patient it caused a rash. Why? It's unusual. Wasn't predicted. It's very rare. Hyporesponse is when the drug effect is smaller than expected. Right? So give a dose and patient doesn't respond that much. Hyperresponse, you give a dose and the effect of the drug is larger than anticipated, right? And so this kind of defines the two ends of the normal distribution and how patients respond to drugs. You have people who respond to low doses, they're sensitive. You have people that maybe are more resistant to the drug. Not that they're drug resistant in a classical sense, like in chemo or something, but they just need more of a dose to achieve the effect. And then most people would have like an average in between those two kind of response. Right, so hypo-responsive, for example, 2 sips of a beer makes the person drunk. Hyper-responsive, hypo-responsive, like 5 beers makes the person drunk. Hyper-responsive, 2 sips of beer makes the person drunk. Like just a very tiny bit of drug, but the response is much larger than you would have expected from the average population. Tolerance is a type of response where we see responsiveness decreasing as a consequence of continued drug administration. So in the presence of continued drug, the response decreases. Tachyphylaxis, the response diminishes rapidly after administration of a drug. Alright, so these are some other types of responses. There are some cases where the beneficial and toxic effect is mediated by the same receptor-effector mechanism. One example would be the alpha-1 receptor antagonist prazosin. which acts on receptors in vascular smooth muscle to reduce blood pressure. But as a consequence, patients may suffer postural hypotension when standing, which is a sudden drop in blood pressure when you go from a seated position to a standing position. This picture would demonstrate how the beneficial and toxic effect can be mediated by the same receptor effector mechanisms. So here's our drug prazosin, binds to the same receptor in the same tissue. One response is therapeutic. One response, however, can be toxic, postural hypotension. So this is an explanation of postural hypotension, and it really just talks to the bolded region in the middle. When a human stands, approximately 750 milliliters of thoracic blood is abruptly translocated downward by gravity, and so the lower regions of the body have to respond, and usually they respond by constricting so that the blood returns to the heart, so that the heart can pump the blood to the brain, and so the person doesn't become dizzy, or in some cases worse, faint. Alright, so postural hypotension is a hypotension that's observed in some people who take alpha blockers when they go from sitting to standing. Okay, and so again, upright posture requires rapid and effective circulatory and neurologic compensation to maintain blood pressure, cerebral blood flow, and consciousness. And so these processes can be affected by alpha blocker, in particular the circulatory compensation, the vasoconstriction. And so fainting is actually an advantageous response in that situation because it will prevent cerebral ischemia. Might cause you to have a head injury though, and so we want to avoid this type of adverse effect when possible, but not always possible. Alpha blockers may cause this type of response in a patient. Now, there can be beneficial and toxic effects mediated by identical receptors, but in different tissues, or by different effector pathways. And the example we'll use here is the digitalis glycosides, which inhibit the sodium-potassium ATPase pump. We've kind of mentioned this in an earlier lecture. Right? They work to make the heart beat harder, have a positive inotropic effect. But they can also cause the heart to have an arrhythmia, which would be an undesired consequence. They're also known to have effects in the GI tract or on vision because of their action at this important pump that's also used in these other tissues. Again, methotrexate, another example, inhibits dihydrofolate reductase, so tumor cell is inhibited, but so too is a healthy cell, right? And so you can't pull apart the efficacy from the toxicity with some of these drugs because they're working at the same receptor but in different tissues. And in one tissue the drug's working well, having an efficacious action. In another tissue, drug may be toxic. So the question is, how toxic is it, and what kind of toxicity would it be? And so the idea here is to always give the lowest dose of a drug that will produce an acceptable benefit. But realize that the complete relief of symptoms may not be achieved when you do that. Okay, so what do? Sometimes you can't completely relieve all the symptoms depending on the situation. Sometimes you may increase the dose and not get much toxicity. It's going to depend on the drug, really. Sometimes increasing the dose may get rid of some of the symptoms, but also increase another toxic effect, or the likelihood of another toxic effect. So this is the idea. How can we avoid toxicity? In some cases, we might actually place the drug right where it's needed. So infuse the drug right into a tumor, for example, to decrease systemic exposure of healthy cells to the drug. So there are different strategies that your book has talked a little bit about. And then we have the example where one drug can bind one receptor in one tissue, bind a different receptor in another tissue. And so example here would be an alpha and beta adrenergic agonist like epinephrine. Epinephrine can bind alpha receptor, epinephrine can bind beta receptor. And so because of its complex pharmacology, it can have both beneficial and toxic effects because of that.